Welcome everyone to our Grand Round series in cardiac imaging. Today we have the pleasure to have Matthias Friedrich, who's a very well-known person in imaging and in cardiology. And he will present today on how artificial intelligence changes cardiac imaging. So we are very much looking forward to your presentation and also the discussion. So Matthias, the stage is yours. Thank you.
Thank you very much for the invitation and for the opportunity to talk about a topic which I consider very important. And by no means I'm a world expert in the technology behind it, but I was already forced to think a lot about it. So I will share with you as much as I can during this time. I want to disclose that I'm also involved in industrial efforts to advance artificial intelligence. I was co-founder of 3 startup companies that in some sense relate to imaging and also include artificial intelligence. Therefore, it's a potential conflict. So when we talk about artificial intelligence, often you see figures like this, which for many people sound complicated. So it's talking about a generative model and learning, generating fake images and discriminative models and so forth. But I want to basically pick everybody up with the simple terms, basically to talk about what we're talking about. So artificial intelligence is simply defined as the ability of machines to perform tasks that usually require a human intelligence. So that's a very simple one. It gets more complicated when we talk about the new models like large language models. And of course, ChatGPT has been on everybody's ears, which it means generative pre-trained transformer. Now, what is that? So large language models, they're based on neural networks, so networks that are basically built like our brain is built, connecting multiple points by what we use neurons and here by simple connections. You train this network to identify patterns, and then it can typically identify context in language. And this is how ChatGPT works when you ask it a question. Now, transformer models have changed everything. So that's came in 2022, 2023. Two significant papers proposed the new method, which came with a much better recognition of context in language. It came with parallel processing, so a much more brain power, if you will. It can train itself by learning from its own mistakes, not just from feedback, but also by feedback. And more recently, in 2023, it was also became possible to use data other than language. In fact, using acoustic information or visual information, and treat these data point as language. So these language models are not language models anymore. They are basically data models. So this is artificial intelligence in general, but we have already talked about learning. So the other terms that we need to keep in mind here is that machine learning is a part of artificial intelligence. It includes these processes that you use to train them. And then there's deep learning, which is a part of machine learning that allows to train these models to identify very specific patterns, for example, in imaging. Now, artificial intelligence itself is booming like crazy. So this is just a graph over time, the number of patent filings on AI. Here, just to show the speed, where it took Netflix 10 years to come up with 1 million users, and Facebook 4 years, Instagram 2.5 years, TikTok 9 months, ChatGPT did that in 2 months. So it was picked up by the community very quickly. But not only that, the technology has also evolved significantly. And this is here an example how Midjourney developed their ability to generate images based on so-called prompts. So you put in a text. In this case, it was show me a young male adult with water drops on his face. And this is how it looks like in the earlier phases. And this is how it looks like now. So as you can see, this was just between 2022 and May 2022, and February 2022 and May 2022. It's now much better. So these models get very powerful. And here's some examples of images that have been created. These are not humans. These are just created from prompts. In this case, it was 4 French people of various ages and both sexes. So you can see it, for us, it's impossible to identify this as a fake image. And you know, these examples that Pope Francis was put into this here, he never did that. He never showed up in this robe. It was also generated by these models. And even going further to change context and be creative in a certain sense to create context. In this case, the screen, the painting, and here Van Gogh's Starry Night, to create dioramas, 3, and here's another one, girl with pearl earring, and you see even facial expressions can be. And now very recently, this also has included video. So these cute golden retriever puppies are not real. They are basically, they are generated by AI. So this is where the generation of data from a known context, but based on a prompt that someone puts in, that's where we are. But it doesn't stop there. This power can be used, for example, to have your secretary working as a digital virtual assistant, not a real person, but being basically a chatbot that knows your schedule, that knows your context, knows your priorities, and then works with you. And even applications that allow you to basically run a full business with that. So you just use this application then to do all your financing, your planning, your bank, and everything. So a lot of power in AI. And this has led to some experts being not only stunned by the abilities, but also fairly cautious. And Max Tegmark, one of the key researchers in the development of these models, said the new AI, and he talked about ChatGPT 4 or higher, is the most consequential step in human history. And this sounds like an overstatement, but if you think about it, it may not be off. So we're talking about something that changes our lives and is already about to do that. So there are certain risks, and I will not have the time to talk a lot about these risks. I will also not have too much time to talk about the necessary regulations, but certainly there are some people out there who say it's not a zero chance that AI will eventually not be controllable, and we as humans will eventually succumb to that. But let's talk about the topic with more focus, which is AI in medicine. So in medicine, you can use this technology to use data from text or audio, but also now video data, to create images. And if you will, a DICOM set of DICOM data is basically text. So this text encodes an image, so you can take these images, you can work with electronic health records or use ECG as signals, you can apply this to metabolomics, DNA, and what have you, or can simple graphs. They can use gold standards based on literature, publications, clinical notes, or other means to train the model on that. And then you can pick your interaction with that and apply this in certain applications. So these could be chatbots for patients, interactive note-taking, and other procedures. And for example, generate then fully worded radiology reports, but I'll come to that, including bedside decisions. Now, when we talk about applications in AI, I like this overview. So these are the most important applications, and I'll quickly go through them. So one is robotic surgery, because in surgery, you can train this, you can train a robot, or use a robot that listens to an AI, and the AI could be trained to perform a surgery in a certain way that is safe to for the patient. You can have, of course, virtual assistants who do nursing jobs. You can assist diagnosis, and we have to be careful between assisted and actually decisions, diagnostic decisions. So far, we only talk about AI-assisted decisions, but this may change in the future. Then image analysis, I'll come to that, of course, drug discovery, and others are automating workflows, ensure data security, but also there's a potential risk there. So it's a kind of two-edged sword. Risk prediction, I'll also come to that, and clinical trials. So you could have a huge database and basically run clinical trials as models for that. So what we can say, AI can help us to get our head around much more data than we could do. So our head is able to deal with a certain number of data and complexity of questions. And this is where AI is way more powerful than we are. AI, on the other hand, is not creative, cannot make up new stuff, or actually very badly so. But in order to do a task that is somewhat predictable, even if it's extremely complex and uses extreme amount of data, this is where AI shines. And this could, for example, lead, and I put this slide mainly because it took me some time to create this image in Midjourney. So it could lead to a future where basically a patient has a complete medical advisor on their smartphone. And this app knows everything about the patient, has all the questions, knows from the past to what the patient responded, and then can make much better, give much better advice than a doctor may be able to do who see a patient maybe once every 3 months. So in AI, in cardiology, AI has been already studied, and this from a paper from this year, but it's already, given the speed of publication, it's already old. It's a few months, but here there was a nice summary of studies using ECG to predict a disease, and then in echo, the applications of AI, coronary angiography, CT, and cardiac MR. So there is already a number of publications, but in the meantime, I can tell you there are more. It's basically every day you see new publications coming up in the area of artificial intelligence in cardiology. A few examples. So this is from a paper that is already almost 4 years old. So now the number of data has increased substantially. We have it at McGill. We have also performed a study, detection of diabetes in ECG curves, and the accuracy 80-96% was also what we could reproduce. So if you would have told a cardiologist 15 years ago, hey, look at your ECG to see whether your patient has diabetes or not, you would have gotten basically a roll eye. But this seems possible, at least these data so far suggest that. So when we talk about imaging now we have cardiology, now let's focus on imaging. There are certain targets where imaging could benefit. And this is assisted or automated image acquisition. So the acquisition itself, make this faster by using sparse data or noisy data or low resolution data, and then use AI to basically fill in the blanks. Then very important for cardiac MR, but also increasingly for CT, extracting tissue pathology from the regular images. So regular cine images or regular CT images they would show certain slightly different patterns in, for example, scar as opposed to others, which we cannot see with the naked eye, but which AI can identify using certain what we call features. Then automated analysis, of course, that's a no-brainer. And also something that is just evolving, that you also automatically integrate other data. So this is where imaging would benefit. The acquisition, making it faster, extract more information, and having a better analysis, and then integrating other data. Now let's talk about some examples. But before that, I want to briefly say the benefits are for the patient, the technician, the radiologist, but also in identifying patterns that we didn't know before. So the patient, of course, could go to free breathing techniques, contrast agent free, especially for MR. That is a very low-hanging fruit. The technician could have an assistant that allows him or her to perform the scan just automatically, just push a button, and based on the history of the patient and the observed initial steps in the localizers, the scan can be performed more automatically. Then the radiologist would benefit from an automated segmentation and evaluation of the regions of interest. And then, of course, you can go further and go to radiomics, then identify patterns that you otherwise would not detect, up to the concept of a digital twin, that you basically create a digital version of your patient, and then based on these data can test even drugs on that. But I will not digress for too much. So some examples are here using deep learning, which is a part of machine learning, a part of artificial intelligence to accelerate scanning. So this is a study we have performed, which is currently in revision, where we could show that we can use sparse data that are acquired in a very short period of time to artificially generate images that look like the original, like usually would look. And then we also saw that the diagnostic accuracy is the same. There's no difference, but it saved time. Another option is to automate shimming, which is sometimes an annoyance and is time consuming. Another example is removing artifacts. This is sometimes extremely helpful in this case where the papillary muscles would not be visible in the original images, but here you can see deep learning. They are then visible. Some people, we have also seen our research, experienced researchers or experienced clinicians, they do not necessarily like that. They say, hey, this image looks too smooth. It's too, I don't like that. I want to have the more noisy image because then I know and I can myself separate that. And that may be true for experienced people, but for less experienced people, this may be a big game changer. You can use DL to correct for motion artifacts. There are data on that. Here, this is an example of CMR. Of course, I come from CMR, so that's why I have a little bit more on this here. So the removal of motion artifacts often helps with coronary arteries, for example. We can use the data to artificially increase the super resolution. This is a study we have done and presented at the last CMR, where we artificially increased the resolution of scans and found that the sensitivity and specificity were not lower. And this is the example how much time you can save by using AI and sparse data. So we found a significant shorter scan time, of course, with sparse data. With keeping the diagnostic accuracy and the quantitative accuracy of the imaging parameters. The next level then is, and I mentioned that before, is to extract what the people call features. So certain patterns or abnormalities in the images. And this has been used, and this is work by the Oxford group around Stefan Neubauer and Vanessa Ferreira, where they used stinging images, anti-1 mapping to generate artificial late enhancement maps. So late enhancement is what we use to display replacement fibrosis. And instead of giving contrast agents, they use this deep learning informed algorithm to generate a late gadolinium enhancement image based on these non-contrast data. So I'm personally not necessarily, I don't think the future will be in artificially generating images that we have used in the past, but even go one step further to come up with a complete non-invasive pathology based on the subtle differences in standard images that can be then used to identify this set of pathology. But this is one of the most important studies that have been done so far. Now, we have also in Montreal worked on that and have found that when we take healthy people and patients with ischemic cardiomyopathy and perform a scan and use standard cine images, in fact, these were oxygenation sensitive cine images, and use a standard deep learning method to train and look for features. This algorithm detected more than 1,000 radiomic features, and 9 key features were identified that were typical for these for differentiating or were powerful in differentiating one from the other. And then when you apply them, and these features are typically related to the homogeneity of the signal, to the roughness of the structure that is there. So you see terms like wavelet form, first order, median. So this is stuff that we, with our visual system, do not necessarily identify. But in this case, we had an accuracy of 82% to identify, to differentiate patients from with ischemic cardiomyopathy from healthy people. And this is not based on things like LV diameters or stuff like that. Now in Heidelberg, we have done some of that, applied that together with an industry partner to identify amyloid disease in the heart based on just images. And not only that, but we were also able to differentiate so healthy from amyloid, hypertrophic cardiomyopathy, which sometimes can look like amyloid, from amyloid, but also differentiating AL from ATTR amyloidosis, which is a very big topic because the therapeutic approach is very different. Long story short, extracting tissues, so features as markers for tissue pathology may give us the opportunity to perform non-contrast scans, which only acquires cine images with a known response to how the tissue is composed, and then to apply that. So that's mainly a CMR. In CT, it's a little bit different, but not much. So here, for example, plaque analysis has been performed using deep learning and automated analysis tools. As you may know, I'm very interested in oxygenation-sensitive imaging, and we use a protocol that uses hyperventilation and then breath-hold as vasoactive maneuvers. And we look at the signal intensity change in the images that are sensitive to hemoglobin oxygenation to identify vascular dysfunction. And when we do that, there is a marker called BMOR. And in a population that they all had abnormal stress tests, so they were highly suspicious for coronary artery disease, we looked at microvascular function between these and the same patients, but with coronary artery stenosis. And we found that the marker that we used had an area under the curve of just 0.65, but when we added machine learning to automatically analyze these images, that area under the curve went up to almost 0.9. And again, there are certain features that differentiate very significantly patients from with coronary artery disease from healthy people. But some of the data are still preliminary. Here's one of those not yet published, where we also looked at scar imaging just from these OS-CMR, oxygenation-sensitive CMR images. So no other techniques, no mapping, nothing else. And we found a decent area under the curve here. So this is all evolving. But I'm 100% sure this will be standard in the future. We just have to standardize some of that. So there is definitely a future for CMR without contrast agents. For SPECT, it's also, so far the first data look very good. So this is a study published earlier this year, where they used the same approach. So they looked for certain what they called components and formed the principal component analysis and could identify components that could, for each of the coronary arteries, identify those with stenosis. And then you can use, of course, these data to go for diagnostic decision-making. So in this case, using this technology, the group used 50 perfusion SPECT images, and of course these are still small numbers, but they could show that actually the accuracy was better with AI and AI-guided diagnostic decision-making. The time was just, of course, there was no time associated with AI analysis, so we can consider that the AI over time will, and we know that already in chest X-rays, for example, will be better than humans to identify certain patterns. That doesn't mean that AI in general will be better in making diagnosis, working with a patient, but at least in identifying those patterns, it will be tough for non-super experts to beat AI. Of course, and I want to just mention that again here, this is definitely dependent on how well these algorithms are trained. If you take inexperienced people and train an algorithm, you will get inexperienced data. So you have to have a large data set and you have to have good data, but I'll come back to that later. So there are tons of other papers, and in the interest of time, I'll have to keep that short, on risk assessment. So we can not only go to a diagnostic decision or assist diagnostic decision making, but also assess risk. And there are several papers, and every week there's another one. So beating conventional risk scores that have been used. Now, when we talk about what has to happen now to integrate this into cardiac imaging, there's been a nice paper by Bettina Bessler and others published a few weeks ago. They propose a workflow of how this could happen. And I want to refer to this paper in the interest of time, but it basically gives like a workflow coming from the data acquisition then to the automatic, to the improvement of image quality, even using sparse data, the automated segmentation, which is basically identifying the anatomy. And here's an example from echo where this includes, for example, strain, so not just distance and signal intensity in area, but also using dynamic data, and then use radiomics then to identify these patterns and get to decisions. And then you can use these data, of course, then to integrate them into your clinical workflow. So in all these steps, from the acquisition to the evaluation, to the analysis, to the interpretation and integration into clinical reports, that all can be improved by AI. Now, when I say can, it doesn't mean that we will be able to do that right away. It means that we have to work on that, but we have this opportunity. And there are big efforts, and UK Biobank provides a data set that is huge and can be used for that. We have, I'm involved in 2 Canadian large cohorts which do that and are also open for researchers to use data. So there are lots of efforts and they begin to carry the first fruits. But as I mentioned before, the data quality is extremely important. So you know this saying, garbage in, garbage out, and that's definitely true for AI. If you train your models with good data, you will have a powerful technique, but if you don't, you don't. Another aspect that I can only touch briefly is the regulations. Would point you to this paper by Medicine. So we have a huge need for developing regulations that allows to classify how these tools will be used. Are these medical devices? Are they just used as a second opinion? Who takes responsibility? Who's liable for errors? So there's a lot that has to be done. The EU has come forward and has already published a first set of rules for AI. But in medicine, we have a whole other world of regulations that need to come. So even if you have all these regulations, a final question is, will we accept that? How do we as clinical imagers respond to that? And there's been a nice paper or a couple of papers that looked at that. And so people usually think that AI is accurate. So in a radiology study, they even say 22% say that AI is superior. But also they say more than 10% say that they would, only 12% they would use AI only. So almost 90% would not leave everything to AI. Now, when it comes to what's the effort for people to introduce that, then it's also as the opinions mostly see it as positive, especially for radiologists or for imagers in general. The time saving is definitely a significant positive aspect, but they're also concerns about how this can be integrated into hospitals. And then the social influence is an important marker. So how does this affect the relationship between patients and doctors? So in this paper, there was a concern about having less time for patients, which I didn't understand, because my hope would be that some of that time that can be saved by all these procedures, at least some of that should be used to actually communicate with your patient, explain what you saw. So this is where you can see that there is a divergence in the opinions. And then what I already mentioned, the liability, accountability. So only 5% of radiologists would assume responsibility for the AI results, which is understandable. Okay, why would I give my basically my reputation and everything away to AI? But there will be more and more difficult questions in the near future. So what if I used AI and I just signed off and was okay with that, and I did not have a good day? And so of course I will have to assume responsibility. But then when it comes to the worst case and there's a court case, so then will companies be responsible? Will the algorithm? Could you blame the algorithm? Or so of course intuitively the doctor will have to take final responsibility, but there are certainly aspects where it will be very difficult. And then of course privacy issues, although I think they're a little bit overblown at the moment. And then of course we all then rely on internet access, and if we don't, we are already in difficult situations if we do not have internet access. But this makes it infinitely worse if I rely on cloud-based algorithms. So this is also an important aspect. So let me summarize. I think AI, especially with deep learning, is becoming, whether we want it or not, an integral part of cardiac imaging. And I also want to point to a quote from Max Tegmark here. He said, even if we wanted, if we all made a decision, let's not do that, it's too late. We cannot stop that. We cannot stop AI. We cannot stop that AI will be part of our lives. So we have to make sure that we do it the best way we can, which means to put safety first, but then use the power without to the best. So when doing that, I think we can improve the efficiency and consistency of cardiac imaging by improving image quality. Shorten scan times is especially important for MR, and we're actually currently testing a scan which is less than 10 minutes and doesn't require any contrast agents. And then using analysis tools that are just don't add any time to that, and that just, from my point of view, ideally create pathology maps based on certain probabilities and based on, of course, trained data sets and algorithms. These results can be integrated in diagnostic criteria and algorithms that summarize clinical, the pretest probability, basically, then the results of the test, and give a post-test probability, which then can be used to communicate to the patient. And let's be honest, there is more and more pressure on imagers and radiologists to come up with a diagnosis. So more and more often clinicians ask, so tell me, what does the patient have? And this is a huge burden sometimes. And if we include these other contextual data, clinical history, etc., into AI algorithms, at least it would be much easier, ideally in a teamwork, to get to the most probable, the most likely diagnosis, and then come up with an informed decision. As I mentioned multiple times, the quality of the training data is critical, and we need international regulations for privacy, liability, that provide the framework so that imagers and radiologists work in a safe space. So with that, I want to thank you very much for your attention. I don't know whether someone will moderate.
Yes, we're just trying to come back. Can you hear me?
Yes.
Okay, perfect. Thank you, Matthias. This was wonderful. I really enjoyed it. AI is really everywhere in cardiac imaging. It's not only on optimizing workflow, it's in the reconstruction, it's post-processing, and maybe even predicting the future at some point. So yeah, this was really impressive. Thank you very much.
Thank you.
And now we will go through we have a lot of questions. That's really nice. So I start with the first one. What are your thoughts on the issue of sometimes lacking a true ground truth? For instance, you showcased artifact-free images, but do these represent the reality, right?
Yeah, this is really a fantastic question. This is something I also think about a lot. And we had this problem before, especially in MR. When you come up with, let's say, a new sequence that is more accurate, then what do you compare it with? Same for biopsy. Biopsy always, the pathologist always creates the impression, hey, I can see it, so we have certain criteria for myocarditis, for example. This is the number of immune cells and so forth, but immunohistochemistry, but what's the gold standard here? So this is a very complicated question to answer in a normal clinical situation. The gold standard from my point of view, at the end of the day, would be outcomes. But of course, you do not have the time and the money and the logistics to perform for every question these long outcome studies. But eventually, this is the data we need to be finally sure. Now, sometimes you cannot rely on outcome data. The example that was given here, artifact removal. So who knows, is this an artifact? So I agree, this is a problem. We should not, as with ChatGPT, you have to know what it's good for and what it can't do. So we have to assume, okay, if it looks like a perfect artifact-free image, we have to be aware, hey, this may just have been, just may have been some manipulation. It looks like an artifact-free image, but kind of the pathology that we had. So that is true. The only good point is that this is what we are already dealing with. As a clinician, I see artifacts, and I'm not sure, is there some pathology below or not? So I will not be able to find out. So I would say, yes, this is a problem, and we all have to be aware of our limitations and the limitations of AI, but on the other hand, it doesn't make it necessarily worse. Having said that, some of these AI images, I can tell you for an experienced clinician, they look too good to be true. So there are certain doubts that you have. But when I look at younger people and look what they can do with these images, I didn't feel that bad anymore, because I also saw the advantage of being less confused about, and some artifacts are really very clear when they don't respect anatomical borders and follow certain patterns. And I just hope that the algorithms that I use and will be eventually brought to the daily use will be good enough to not do a bad job. But this is a problem that will stay with us.
Yeah, that's really true. Now we learned also from the non-AI images and now see the AI images, so we can somehow maybe deal with it. However, the new generation most likely will only be trained on the AI images, and so it might get a little bit more difficult for them. So with this, the next question comes. You showed the setting workflow.
The setting workflows.
Yeah.
I see that. Yeah.
What
So
is
what's
the
the role of the imager? So
Yeah.
that's an interesting question. And of course, there are these horror scenarios. Radiology will be useless in 5 years and so that. We all know that the inertia in medicine is working in slow motion. So it will not happen necessarily in this generation. But I think radiologists will not be able to do their job if they don't embrace AI, if they do not learn how to deal with it. So we have to, we as imagers have to make sure we understand these tools and use these tools. But fast forward, I think radiologists and imagers in general will be probably the most important people when it comes to diagnostic decision making. And I always point to Finland. In Finland, you have diagnostic centers and you have the treating physicians. So the diagnostic people, like tumor rounds or cardiac team, so cardio teams, where experts sit together and then come together to a conclusion. This is a burden that will now more and more lie on radiologists and imagers, because we are all visual creatures. We believe images and more than we believe text or data. So I think it will be more than it used to be, that the imager will be asked, okay, what's happening now? So what do we do? And the AI will help the imager to eventually carry that burden. So I think for quite a while, we will continue like that. It will be easier for imagers, but then instead of being basically just replaced by AI, we will have to be the people who communicate that to the treating physician and to the participants. So I think my guess is that the task of the imager will be slightly different, will be more patient-oriented. I may be wrong, but this is where I see a need, and with the more powerful tools, we hopefully will spend less time looking at screens and typing or dictating, but really more time with making sense of that and then help in a team to come to good decisions.
May I also ask a question? Sorry for being now a little bit negative. After all this this fantastic outlook and what the future will bring. Now I have one problem always with these topics. Why there is not a single tool helping me currently in my clinical role as a radiologist for diagnostics? There is not a single tool there. We tried so many, we deinstalled everything. There is not a single tool there. And this is such a big contradiction to, you know, this 2 billion of startups and publications. And we did also several by ourselves. Some were even mentioned here by Bettina Bessler when she was here in Zurich. But how can we explain this discrepancy? I see that there are some AI tools, you know, working in the preparation, in scan planning, 3D camera. I'm always talking about CT. But when I look in our clinical routine, I see, you know, when I go to MR, I see people, you know, they are, you know, with the hand, they draw circles around the ventricle. And then I see a presentation and they say, yeah, this is a low-hanging fruit for AI. We do everything with AI. But this is, why is this, where is this discrepancy? I don't understand that. What happens? Why is it not here? It's not only regulatory, I personally believe.
No, as I mentioned, there's certainly inertia. So regarding the analysis tools, at least from what the centers I know, the centers who still have to draw circles is now the minority. I was certainly one of the people who did it longer than usual because I have always included papillary muscle intrathecals into the myocardial mass because I thought it was anatomically correct way. And that was more difficult for automated tools, but if that can be done now, and in our center, we do not draw contours. We correct them if we see mistakes. So I think these tools will be coming, but of course, I cannot speak now for Zurich or for other centers. These tools so far maybe were still a bit too complex, too complicated, too time consuming. But I'm 100% sure that, and there are now the software that is now out there that basically analyzes CMR images automatically. When you open the scan, you already have all the contours, you just have to review them. So I think a lot of that is already happening. But as I said, there are IT departments, there are decisions of hospitals to either use this or that technology. The standardization is not that great. There are patents that do not allow others to offer this technology. So there are certain roadblocks. But on the other hand, I think things have already significantly improved, and they will improve. Just from when I look at our images, it took 8 hours for some of these analyses for the oxygenation sensitive MR, and it's now down to 30 seconds, and I don't have to touch the computer for that. So I think they are coming. I cannot answer why in certain centers there's basically more concerns than others.
Okay. Yeah, we see this also with introducing more AI. I'm alluding also to one question from the chat that when you start suddenly denoising your images, all your analysis software do not work anymore because they were not trained on data. Strain images might not be possible because the features are lost. And so on and so on, right? So it might be all this also these features in the images where you suddenly see a scar will not be possible because it's erased. So I think
it's a great point. These faster sequences, they sometimes do not allow for the feature analysis. We actually use standard CNA images and not the fast sequences and not the deep learning sequence for that, you will have to retrain them, of course. Yeah. Or sometimes may not be possible. You have to get to noisy sequences, but our fingerprinting has shown that noisy data may still have a lot of information.
Yeah, so it's really fascinating, and we are you have shown that actually we are still very early in the development, right? There are so many companies, of course, and it's developed, but we are still very early in applications, right? So
Yeah.
I think
Yes.
there's
Yes.
still a long way to go when we think of other developments
Yeah.
in medicine. But yeah, Hatem is absolutely right that there are these hypes, but they still do not help us almost at all
Exactly. That, yeah.
in daily
That,
practice, right?
yeah, absolutely. And what I try to get across or hope to you as a basically a take home is we have to embrace it, but it doesn't mean that we have to agree with it. It means that we have to understand what we're doing and then carefully move step by step to integrate it, because the potential is huge. But if we don't do it well, if we just take an algorithm and just take it as it is, then we may do more harm than anything else. Yeah, of course.
And we still need to have a look at the images. I think this is certainly very important. It's not just run the analysis and then have a report output and maybe never seen an image, right?
Yeah. But where it, for example, helps a lot. So my son is a radiologist, so he told me for him it would be fantastic if he has a stack of 50 CTs to read, if the AI would identify, just have a first look through these 50 and say, hey, look at case 36 and 42 first, because there may be a bleed. So look at them first. So this would be a huge help in basically pre-screening these images. So there are certain aspects where it would not only improve efficiency, but also quality of care, because in this case, any minute would help to correctly treat patients.
Yeah, that's another very good application, right? Because we know it from clinical practice, right? That we usually go through the list and not according to maybe what is more important, right?
Yeah.
Do we have there's maybe one more question also from the chat. There's a question, what do you think about open source sharing image databases to get better training data sets actually?
I'm always a friend of open science and open source, because you can integrate the experience and expertise of other people, and the problem of black boxes, which was also in one of the questions, of course, is a significant one. If you do not know what the algorithm is doing, then of course it's a bit harder to find out is what this algorithm is doing, is it correct what it's claiming. So in general, I'm for open source activities and shared activities and a collaboration between industry and academia to improve these algorithms over time. And this is not some effort that a single company can do within a few years. This is a concerted effort of many, many people. And the more we can integrate, the better. And open source is definitely a very good way of doing that. I mean, I'm involved in industry and academia, so I know the limitations on both sides, and I know about the importance of doing both. None of them can do any of that alone. But we have to respect the interest of academia. We have to respect the interest of the industry. But if we do that well and integrate these efforts, and open source certainly gives still ways to basically award academic success and business success. I think there are ways to do that, and there often these are models where you have a shared benefit that you distribute. So I think there definitely are ways to integrate open source and then use that. So I'm really all for that.
And another one which maybe we can also, your thoughts is on workload, right? So it might immensely increase workload. The idea is actually that it should reduce our workload, but at the end it might increase it because we anyhow have to look at the ones that were potentially normal ones. Maybe we have to double check. So what do you think about that?
Yeah, no, it's definitely a valid concern. If the hamster wheel is just getting to the next gear because we're faster, that doesn't help. So this also touches a point that medicine is often, especially in the US, is primarily a business. And I know I may sound a bit too cheesy here, but I think we have to, as doctors, we have to freaking get to the point where we act as physicians and not necessarily as business people or as and running this the most efficiency. And I think AI gives an opportunity for people who want to do that to reduce their workload and do more of what they want to do. Whether reimbursement codes will follow and all that, I of course I do not know. And our healthcare system, there's a whole nother slew of problems. But at least there's the opportunity to reduce the workload, to make lives simpler. To me, when I look in an emergency room or in reading rooms, I don't think in 50 years from now, people will look back and will find that very smart, that we spend 80% of our time actually looking at screens. I don't think that's a smart way to spend our lives. And AI will give opportunities to reduce that. And I may be too optimistic here, but if we don't strive for that, then of course the chances are even lower that we get there.
Yeah,
there's actually an excellent question from Sebastian Kozerke, who said, why should we denoise images if the machine learning algorithm has already included that? And I totally agree. That's why I think the future for CMR in this case will not necessarily be in the denoising. And I also don't think that we should generate artificial T1 maps based on other, because T1 maps are just a vehicle. And a late enhancement is just a vehicle. So we have to get to a point where images tell the story and not tell a code where someone has to decipher the code and then tell the story. So I absolutely agree that the noise is part of the story and helps the algorithm to extract the correct information.
Okay, Hatem, do you have something to add or?
No further questions. I think we had a fantastic discussion, a very vivid discussion. We could talk for a long time about these topics.
And we will all have to talk more about that. This is just the beginning, and we all I just can. I have also already spoken with politicians, and the knowledge is the experts in AI. They are basically they're far ahead from us as people who apply that, but we are far ahead from people who have to write the regulations. So we have the responsibility to find out which algorithms work, which don't, and apply this carefully and generate the workflows that eventually will improve care. So we have a lot of responsibility, and we can only assume this responsibility if we understand what we're doing, which doesn't mean I have to understand Python, or I have to understand which algorithms, which generative models I should know what they use, which model, but how it works, I may not need to understand that. But we have to have a good quality control and have to basically guide both sides, the technical experts and the people who write the regulations. So that's why, as we are in this meeting, we have an important role to play here.
There's one comment from the chat which summarizes it. An excellent talk, both exciting and frightening simultaneously. So, yeah, yeah,
as often in life.
yeah. Actually, that's true. Yeah. So again, thank you very much, Matthias, for being with us. Even you're having your vacation at the moment. That was very kind of you, and sharing all these ideas and a glimpse into the future that It won't get bored. We won't get bored for sure, and and I think
No,
we will still have
definitely
enough
not.
work also in the future, and the next generation will have this as well. This, thank you again, and I will hand over to Hatem for the last and final word.
Okay, so yeah, I think everything was said already. Thanks again to Matthias for sharing his thoughts about this exciting topic. It was a fantastic lecture. Thanks, everybody. Stay tuned.
Thank you very much for having me, and all the best to everybody.
Thank you.